Hi everyone, welcome to my channel and we're going to look at sinusitis. Now what is sinusitis? Now when you have an inflammation of the lining of the paranasal sinuses, we say that you have sinusitis. Now signs and symptoms of sinusitis. Now there is pain over cheek that is radiating to frontal region or teeth, increasing with straining or bending down. And there is redness of the nose, cheeks, or eyelids. There is tenderness to pressure over the flow of the frontal sinus immediately above the inner cathars. There is postnasal discharge, a blocked nose, persistent coughing or pharyngeal irritation, facial pain, and hyposmia. Let's look at acute bacterial rhinosinusitis. Now, because the nasal mucosa is simultaneously involved, the sinusitis rarely occurs without concurrent rhinitis. So, rhinosinusitis is the preferred term for this condition. So, when there is persistent symptoms longer than 10 days or worsening of symptoms after 5 to 7 days, purulent discharge, and moderate to high-grade fever, it suggests a secondary bacterial infection. In this case, we'll call it acute bacterial rhinosinusitis. So, signs and symptoms of acute bacterial rhinosinusitis include facial pain or pressure, especially unilateral. There is hyposmia or anosmia. There is nasal congestion, nasal drainage, postnasal drip, fever, cough, fatigue, maxillary dental pain, and then there is ear fullness or pressure. Treatment. Now, treatment of acute sinusitis consists of providing adequate drainage of the involved sinus and appropriate systematic treatment of the likely bacterial pathogens. Now, options for medical drainage include use of oral alpha-adrenergic vasoconstrictors, for example, pseudoephedrine and phenylephrine for 10 to 14 days, and also use of topical vasoconstrictors, for example, oxymetazoline hydrochloride for a maximum of 3 to 5 days. Now, when we come to acute bacterial rhinosinusitis, an empirical antimicrobial therapy should be initiated immediately after the clinical diagnosis of bacterial infection. Amoxicillin, a combination of amoxicillin and clavulanate, is the first choice antimicrobial agent. Doxycycline is an alternative in adults with penicillin allergy. And also children with non-type 1 penicillin allergy may be treated with a combination of a third-generation oral cephalosporin and clindamycin. Fluoroquinolones are reserved for patients in whom first-line therapy has failed. Also, it's important to know that intranasal corticosteroids are recommended as an adjunct therapy in patients with a history of allergic rhinitis. So that's it for this video. Thank you so much for watching. If you have any question, leave it in the comment section below, and don't forget to like and to subscribe to this channel for more.